Good afternoon, everyone. I'm Debra Reisinger. I'm from Indiana University School of Medicine. I'm really excited that you all are here to join us for our symposium. We're focusing on emotion regulation in autism, and more specifically, some novel clinical and treatment outcome measures. We have a wonderful lineup of speakers for today's event. Starting us off will be Deanna Swain from Weill Cornell Medical College. Then next, we have Marika Coffman coming from Duke University School of Medicine. After that, I'll be joining you guys back for our third presentation. And then to wrap things up, we have Lauren Schmitt from Cincinnati Children's Hospital Medical Center. And then to summarize all of our awesome talks this afternoon, our discussant is Rebecca Shaffer from Cincinnati Children's Hospital Medical Center. We hope you enjoy our lineup of talks for today.
Hi, my name is Deanna Swain, and I'm a postdoctoral fellow coming to you virtually from New York. Today, I'll be talking about a study that is exploring the link between autism symptoms and emotion dysregulation in young children with autism. Emotion dysregulation occurs when emotions are inappropriately and ineffectively regulated. On the other hand, emotion regulation is conceptualized as processes through which individuals modulate their emotions to appropriately respond to the ever-changing environmental demands. Previous research in the general pediatric population suggests that impaired emotion regulation leads to different forms of psychopathology, including internalizing and externalizing disorders such as anxiety and ADHD, and can manifest in a variety of ways, such as difficulty calming down when upset or exhibiting more extreme emotions. These constructs have been measured in a variety of ways, including observational, physiological, and parent or self-reports. The CBCL is a well-established parent report measure of child emotional and behavioral concerns. Recently, authors have derived methods for calculating an emotional dysregulation construct. The dysregulation profile consists of the compositive T-scores of the attention, aggression, and anxiety to depression scales and can be measured in continuous or categorical form. The EDI, or the Emotion Dysregulation Index, is comprised of 16 items that were selected via expert rating process. Individuals with autism present with high rates of emotion dysregulation and co-occurring psychopathology. Several hypotheses have been put forth to account for heightened emotion dysregulation, such as core autism deficits. In 2019, Sabralik and colleagues conducted a systematic review of emotion regulation studies specifically in younger children with autism, that is, less than 6 years old, as many studies to date have focused on adolescents and adults. Results yielded mixed findings regarding the relationship between autism symptoms and emotion dysregulation. For studies that relied on parent report of both constructs, significant relationships were identified. However, several authors have noted the possibility of shared informant variants. Clarifying the nature between ASD symptoms and emotion dysregulation can help inform our understanding of developmental processes and approaches to clinical intervention. Our sample consisted of families participating in research-specific studies as well as clinic diagnostic evaluations, which were conducted here at the Center for Autism and the Developing Brain and at the UCSF Center for ASD and NDDs. Initial diagnostic groupings were created based on primary diagnosis. For example, the neurotypical group had no confirmed diagnoses. The ASD group included ASD only, as well as individuals with co-occurring psychopathology, and the non-spectrum group included children with intellectual disability, language and communication disorders, externalizing and internalizing disorders. We used both the dysregulation profile and the emotion dysregulation index approaches to examine differences in emotion dysregulation across groups and as an outcome variable. ASD core symptoms were measured by calibrated severity scores for social affect and RRBs using the ADOS. As you can see, significant initial group differences were noted in both measurements of emotion dysregulation, age, and cognitive profile, among others. Using the categorical classification of emotion dysregulation from the CBCL-DP, we see initial differences in rates of typical, moderate, and severe emotion dysregulation across each diagnostic group. We next conducted an ANCOVA to control for age and nonverbal IQ. Results show significant differences across our 3 diagnostic groups. Post hoc comparison with Bonferroni correction indicates significant differences between the neurotypical and ASD group, as well as the neurotypical and non-spectrum group. However, there were no differences between the ASD and the non-spectrum groups. Results from this initial aim spurred subsequent exploratory analyses to compare the differences in autism and non-spectrum subgroups based on primary and secondary diagnoses. As you can see, within our non-spectrum group, we had our smallest sample, which consisted of internalizing disorders and included diagnoses such as separation anxiety and specific phobia. Our next largest group was externalizing disorders that included oppositional defiant disorder and ADHD. And our largest group within the non-spectrum group included intellectual disability or language and communication disorders such as speech sound disorder and mixed receptive expressive language disorder. Within the autism group, the majority of children received a diagnosis of ASD only. And we saw similar percentage trends within the non-spectrum group with the lowest rates of autism and internalizing disorder and the highest group of ASD and comorbid ID and language and communication disorders. We then reran our ANCOVAs with these new group comparisons, and post hoc comparisons with Bonferroni correction reveal significant differences between internalizing and ASD only, internalizing and ASD plus ID, and just the ID and LD compared to internalizing. Initial trends appear across ASD and comorbidities. However, these exploratory results should be viewed with caution due to the small sample size and variable sample size across diagnostic conditions. For AIM-2, we ran separate hierarchical linear regressions to examine predictors of emotion dysregulation in 2 samples. We ran all the analyses within ASD and non-spectrum combined, as well as ASD only. Predictors were entered into 3 blocks. The first block included gender, age, maternal education. The second, nonverbal IQ and observed spontaneous language level. And the third, autism symptoms. Across all sets of analyses, core ASD symptoms, as noted on the ADOS, were not significant predictors of emotion dysregulation. Interestingly, 3 predictors remained significant across all analyses: maternal education, nonverbal IQ, and language, such that lower levels of maternal education, higher nonverbal IQ, and lower observed spontaneous language predicted higher rates of emotion dysregulation. Similar to previous studies, we found that young children with autism were reported to experience higher rates of emotion dysregulation compared to neurotypical children. Replicating results from our non-ASD specific samples, we saw that expressive language and maternal education play an important role on child emotion regulation. Some of our findings differ from previous studies. For example, our ASD and non-spectrum group showed similar rates of emotion dysregulation. However, a study examining severe emotion dysregulation in older children found higher rates of emotion dysregulation in autism compared to children with ADHD. It's important to note that children in our non-spectrum group seen through our clinic were seeking an ASD evaluation and were diagnosed with other types of psychopathology other than ADHD. As a result, our younger sample may present with higher emotional and behavioral concerns compared to other samples. Finally, compared to some previous studies, we did not see significant relationship between core ASD symptoms and emotion dysregulation. The large sample size and comprehensive phenotyping were significant strengths in our study. Providing this level of clinical information in future research will help disentangle questions regarding emotion dysregulation and co-occurring psychopathology. We also encountered several limitations within the current study. While we provided an objective measure of autism symptoms as measured by a standardized tool, we relied on parent report for our outcome variable. Future studies should explore multiple informants, such as teachers, mothers, and fathers, as well as multiple methods, such as physiological responses and observational or behavioral measurements. Finally, our study was cross-sectional in design. As such, results should be viewed with caution and tested in longitudinal studies to explore the direct and indirect pathways between ASD symptoms and emotion dysregulation. To end, I'd like to acknowledge my mentor, Sophie Kim, and everyone who was involved in making this study happen. And especially thank you to all the participants and families.
Hi, thank you so much for the opportunity for letting me present this work, utilizing data-driven brain connectivity subgroups to examine emotion regulation patterns in adolescents with autism, social anxiety, and controls. As others in this panel have discussed, emotion regulation is the ability to modulate experiences and expressions of emotions in a socially acceptable manner. It's a way of controlling the intensity of one's emotions, either at a conscious or unconscious level, either before or after a triggering event. And ER difficulties develop in a number of ways, but they've also been linked with mental health outcomes, including anxiety and autism. In social anxiety in particular, emotion regulation difficulties are associated with hyperreactivity and cognitive patterns. Whereas in autism spectrum disorder, autistic people tend to have more difficulties with emotion regulation, are less effective at employing emotion regulation strategies, and use less healthy strategies for emotion regulation. However, the brain mechanisms underlying these different conditions are not well known. And so the goal of this project is to elucidate those patterns of ER difficulties. So one way to do this is to look at resting state brain networks, which might help us characterize these emotion regulation difficulties better, improve risk detection for later development of emotion regulation difficulties, and can also help us tailor interventions based on neural architecture. Two brain networks that might be relevant to emotion regulation difficulties include the salience network, which is responsible for allocation of attention, so attending to a threatening stimulus versus a neutral stimulus, and the default mode network, which underlies self-referential cognitions and inflexible thinking. So we sought to examine whether connectivity patterns between the default mode network and the social salience network relate to diagnostic status, or are there similar patterns across diagnostic patterns? So we hypothesized that transdiagnostic patterns would be evident between the default mode network and the salience network. We were also curious how DMN and salience network connectivity might relate to behavioral measures of emotion regulation. We believed that parent and self-reported ER difficulties would relate to both neural groupings as well as diagnostic groupings. In order to study this, we recruited 35 participants who either had a diagnosis of autism spectrum disorder and comorbid social anxiety disorder, social anxiety alone, and typically developing controls. They underwent rigorous phenotype clinical characterization, so including cognitive, ADOS, clinical interviews, and the adolescents reported on their emotion regulation difficulties with the DERS. Participants also completed a 5-minute resting state scan so that we could examine those neural networks. In order to process the fMRI data, it was all conducted through CPAC. And we identified 11 ROIs, or regions of interest, for each participant, 8 relating to the default mode network and 3 related to the salience network. And then we used GIME, which is a graph theoretical approach on each individual participant's data to identify individual patterns of connectivity along those different regions of interest. And then a community detection algorithm to identify whether there are distinct subgroups that characterize distinctive salience network and default mode network connectivity patterns. And then once we had these subgroups identified, we wanted to examine whether connectivity patterns differed related to diagnostic group or if it was transdiagnostic. To do this, we conducted ANOVAs and post hoc t-tests to determine the groupings for emotion regulation subgroups. And then to examine the behavioral measures, we again conducted ANOVAs on the behavioral differences between the groupings, as well as within group, meaning within diagnostic grouping correlations for emotion regulation subgroups. And what we found were two distinct subgroups. We had subgroup A, which had 16 participants, and subgroup B with 19 participants. And you can see that they did not differ significantly in their IQ scores or their gender. And they also did not differ in terms of their diagnostic status. You can see a relatively equal number of participants from each diagnostic group. And in order to give you a picture of what these two subgroups look like, you can see subgroup A. So these red nodes are the default mode network, and these yellow nodes are the salience network. And you can see that subgroup A has hyperconnectivity, meaning that it has more connectivity between the networks as well as within the networks, whereas subgroup B has relatively little connectivity between the networks and even within the networks. So we'd call subgroup A hyperconnected and subgroup B hypoconnected. And then we wanted to determine whether the emotion regulation ratings differed based on subgroups. This is a big table here. So the main takeaway is that there were not statistically different scores on the DERS between subgroup A, which is that hyperconnected group, and subgroup B. So then examining within each diagnostic group, first within the ASD group, again, we don't find a difference in how they're rating themselves in terms of emotion regulation difficulties. However, when we look at the social anxiety group, we see that this subgroup B, this hypoconnected group, compared to the hyperconnected group, is showing more difficulty with awareness and clarity for their emotion regulation strategies, meaning the hyperconnected group is showing improved ability in awareness and clarity. Then within the typically developing control groups, we see the opposite pattern emerge. So we see that the controls are having, that are hyper-connected, are actually having more difficulties with clarity on the emotion regulation scale. So what we see is hyperconnectivity within and between salience and default mode networks may be associated with specific difficulties in emotion regulation abilities during typical adolescence compared to atypical adolescence. The TD adolescents with hyperconnectivity had more difficulty clearly identifying their emotions, whereas the social anxiety group with hyperconnectivity had better ability to clarify their emotions, as well as better awareness. The ASD-specific brain networks, brain behavior relationships may be better observed in other brain networks. One thought is that they might have more in the frontal network or the executive control network is where we might see more ASD-specific difficulties. Another reason we might not have observed difficulties in emotion regulation differentiating between the two subgroups is that the DERS is a self-report measure, and it's associated with high rates of alexithymia and ASD, as we found in a paper that should be hopefully coming out soon. There's some hope for this in that in these findings, in that the combination of behavioral information and resting state fMRI data may provide an important tool for tailoring intervention approaches, including mindfulness approaches for groups that might need to tampen down those ER responses, and the neurofeedback for groups that might need to increase neurofeedback, that might need to increase communication between those networks. We also intend to examine the triple network model of emotion dysregulation, which includes that executive control network, to test whether those frontal lobe differences might emerge in the ASD group. And then finally, we want to examine contributions of other co-occurring psychopathology, whether ADHD or the dysregulation index on, for example, the CBCL or the YSR. So broadband measures of psychopathology might show differences in connectivity. And then finally, none of this work would be possible without my fabulous research team of research assistants and faculty mentors, as well as my funding sources, and of course the participants and their families. Thanks so much.
Hi everyone. As I mentioned earlier, I'm Debra Reisinger. I'm from Indiana University School of Medicine. I'm really excited today to talk to you guys about some of the work that I completed while I was a postdoc at Cincinnati Children's. The focus of this talk will be on utilizing a biobehavioral approach on emotion regulation treatment outcomes in children and adolescents with autism spectrum disorder. So my co-presenters have already done an awesome job describing emotion regulation and emotion dysregulation. So I'm just going to jump right in to talk about some autism-specific predispositions to emotion dysregulation. So we know that individuals with autism are at higher risk for developing emotion dysregulation. And this can be due to several factors, such as difficulty reading social and emotional cues, limited emotional language, poor problem solving, biological risk, poor self-awareness, reduced flexibility, increased sensitivity to change, and increased sensitivity to environmental stimulation. So putting all of these characteristics together, we're going to see a higher risk for emotion dysregulation. And it's this idea that emotion dysregulation may be an inherent part of autism itself. And so all of these facets can then put them at higher risk for poor outcomes and other psychopathology. So some of those outcomes that we might see could include academic difficulties, poor transition to college or adulthood, increased use of intensive crisis services, increases in aggression or problem behavior, increased healthcare costs, worsening deficit, social deficits, increased rates of psychiatric symptoms, and high rates of family stress. So because of this, our group at Cincinnati Children's developed the intervention Regulating Together, primarily spearheaded by Dr. Rebecca Shaffer. This intervention combines a lot of different facets that we see in intervention in children with autism, including ABA, CBT, mindfulness. We use lots of individualized supports. We use lots of reinforcement strategies, and it also includes this concurrent caregiver and child group format, which really helps with post-treatment durability and maintaining and continuing to work on those skills outside of the treatment program. So really quickly, I'm just going to describe the curriculum for you. So we have two different formats. We have a child material format and an adolescent material format. In our child material format, we have 10 sessions total. So we look at emotions, we look at body signs and triggers, rating our emotions, problem sizes, relaxation, positive and negative thoughts, cognitive flexibility. And then our adolescent curriculum has a similar layout. So we have several different sessions, but we do kind of increase some of the content for the older children. So that might include mindfulness, we talk about distress tolerance, we double up on cognitive flexibility, and we also introduce this idea of radical acceptance. So when we're thinking about physiological arousal, we know that arousal is critical for steering and tuning our emotions and our behavior. So I'm just going to give you a quick rundown about physiological arousal. So our heart rate activity patterns have been found to be stable across development from infancy into childhood. And this green line here represents the optimal zone of a regulated nervous system fluctuating appropriately between the sympathetic and the parasympathetic systems. The red line here represents a dysregulated system. Heart rate that's limited in flexibility and does not vary according to task demands is associated with other pathology. So peaks at these higher levels are considered hyperarousal, and peaks at these lower levels are considered hypoarousal. So when we're thinking about physiological arousal in typical individuals, we know that heart rate variability has demonstrated to be a strong objective biomarker of emotion dysregulation in the typical population. So in typical development, we see a greater ability to regulate our physiological arousal associated with fewer behavior problems. We also see a strong relationship between physiological arousal and other symptomology. And lastly, we see that physiological arousal is associated with increased rates of aggression. Within autism, we also see atypical physiological arousal, and this is common across heterogeneity. Overall, we see elevated mean heart rates, and we also see difficulties with modulating arousal across tasks. And there's also been this suggestion that arousal leads to maladaptive behaviors when the demands exceed their coping abilities. So heart rate variability may be an important predictor to which individuals with autism will benefit from treatment, while also providing information about biological mechanisms associated with therapeutic gains. So in this present study, we collected some pilot data using heart rate variability in a treatment trial addressing emotion regulation deficits in autism. And we looked at the feasibility of heart rate variability as a biomarker. And we looked at heart rate variability in relation to our clinical outcomes. And lastly, we looked to see if heart rate variability was sensitive to treatment change across time. So within this larger trial, looking at regulating together in individual autism, we had a subset of participants, total of 17, who were 86% male. Ages range from 8 to 18, and everyone was diagnosed with autism. Our measures, we used the Pharos monitors to collect heart rate data, and we were specifically looking at the change in heart rate over time. And how we calculated that was using the root mean square of successive differences between neighboring RR intervals, so that time in between heartbeats. Then we compared this to our clinical outcome measures, including the emotion dysregulation inventory, clinical global impression scale, the aberrant behavior checklist, and the flexibility scale. So our treatment, or the entire study as a whole, had 3 different phases. So we had this baseline phase, treatment phase, and follow-up phase. So at baseline, participants entered the treatment at week 0. We collected data upon entry. We then collected a second baseline visit at week 5, right before beginning treatment. We collected data at week 10 at the end of treatment, and then we had 2 follow-up visits at week 15 and week 20. So with regards to our heart rate variability task, there were 3 components. The first component was a baseline video. So participants were instructed to watch about a 5-minute non-engaging baseline video. Then they were asked to relax for 2 minutes. So they were given some instructions to relax how they felt comfortable, and we provided some materials as well to help facilitate this, like squishy items or markers and paper, however they wanted to relax themselves. And then the last task was a breathing task. So we instructed the individuals to breathe for 2 minutes, and we also provided some visuals that we commonly used in our group. So we were specifically looking at the change from baseline to task 2, that relaxation task, and baseline to task 3, that breathing task. And this was to test our hypothesis that characteristics of responders would predict treatment outcomes. And so to do this, we conducted some regression analyses to examine any predictors of change on primary outcome measures from pre to post treatment. We also included age as a covariate in all the analyses. So for feasibility purposes, we collected a total of 201 recordings across all 17 participants. And of those 201 recordings, we had 100% tolerability. So each time and each visit, all the participants were able to wear the monitor successfully. And on top of that, we had 100% data collection. So we were able to get usable, analyzable data from all participants across all recordings. In relation to our clinical outcome measures, for task 1, we found that was significantly related to our clinical outcome measures, including EDI reactivity and EDI dysphoria. We also found a trending interaction with time to predict improvement on the ABC irritability subscale and on the CGI. For task 2, the breathing task, we had a significant interaction between heart rate and time point on a subscale of the flexibility scale, specifically the generativity subscale. And then we found some trending interactions with time to predict improvement on the CGI-I and the flexibility total score. With respect to sensitivity to change, of our 17 participants, and more specifically for task 1, so that relaxation task, we found that task 1 was sensitive to change over time for about 65% of our participants, or 11 out of 17, who completed the program. So next I'm going to show you some sample data for one participant. So right here we can see some pre-treatment heart rate data across the 3 tasks. So we have baseline at the top, relaxation in the middle, and breathing at the bottom. And then here is their post-treatment data. So we can see here that there's some nice staying within that optimal zone. And then even with the breathing test, you can see some nice like up and down peaks and some slowing of that heart rate variability across time. So in conclusion, we found preliminary evidence for high feasibility and tolerability of collecting heart rate data in children and adolescents with autism. We also found evidence of construct validity with several of our clinical outcome measures that were relating to core deficits of emotion regulation. We also found predictive utility of the heart rate variability on improvement in clinical outcomes, as well as sensitivity to change across time during the intervention. And lastly, this suggests that heart rate variability might be a promising biomarker linking biological mechanisms and therapeutic gains. So lastly, I want to thank everyone, especially Dr. Shaffer and all the clinicians that were involved in this treatment, as well as our research coordinators. A huge thank you to our participants and their families, as well as the neurobehavioral research team and all the support staff at Cincinnati Children's. And then lastly, here's our research board.
Hi, I'm Lauren Schmitt, and I'm going to be talking to you today about the feasibility of a probabilistic reversal learning task as an outcome measure in an intervention targeting emotion regulation in ASD. This will be a nice continuation with what Dr. Reisinger presented on, as it does use the same intervention regulation together. I will note that Dr. Rebecca Shaffer and I created the curriculum for. So there are numerous ASD-specific predispositions to emotion regulation, and today I'm going to be really honing in on this reduced flexibility, and that's where this idea for this outcome measure. So cognitive inflexibility in the context of emotion dysregulation is going to look like a lot of different things, from difficulty coping with changes in the environment to failure to use different problem-solving strategies, being stuck in negative emotions or negative thought patterns, rigid implementation of rules and routines, intolerance to uncertainty, and trouble taking another's perspective. So a lot of this cognitive inflexibility can both lead to emotion dysregulation as well as maintain emotion dysregulation. Within the curriculum of Regulating Together, we do have specific sessions focused on cognitive flexibility, and this is going to be looking at adding flexible and unflexible vocabulary, increasing awareness of what flexibility versus inflexibility or rigidity looks like, incorporating a flexibility scale, so helping note how flexible you are in certain situations versus not, and then giving some concrete examples of how to increase your flexibility within certain situations. The inclusion criteria for the Regulating Together pilot study is as follows. Again, you have to have an ASD diagnosis, IQ above 65. So I'm really going to focus right now on the probabilistic reversal learning task, which was previously created by Drs. John Sweeney and Matt Mosconi, as well as myself previously. And so this has been previously validated for use in individuals with ASD, but it has not been used in the context of a behavioral intervention trial yet. So during this task, your job is to choose the animal in the correct location to get points. And after a while, that correct location may get changed, and you need to find the animal in the new correct location. You need to get 8 out of 10 consecutive correct choices in order for the reversal to happen. And then again, you're going to need another 8 out of 10 consecutive correct to end the trial. And so those are the total number of trials, and you have upwards of 100 trials to get that goal. The uncertainty or probabilistic element of this is that you're only receiving corrective feedback 80% of the time. So in 20% of those trials where you are choosing that animal in that bottom corner, it's going to give you the X instead of the coin because the other one is going to be the quote unquote correct location. And so there's this uncertainty element that is added to it in having to figure out when to reverse or when not to reverse. In addition to trials to criterion, we care about errors and error types. Perseverative errors are when you continue to choose the response even after the reversal. And then a regressive error is whenever you establish that new correct response, but then fail to maintain it and go back to the original response. Looking at feasibility or the completion rates over the different time points at screen, baseline, treatment, and follow-up, we have high success in getting these individuals to complete the task. And we also note that there have been some individuals who failed the pre-test. A lot of in that pink zone, that is COVID, and so we are not able to collect data at that time. And then the darker blue is no-shows or kind of having to leave the study early. So when you subtract all of those like pink and dark blue, you really have high feasibility across all of these sessions. And so we have a 96% completion rate, 2% failed that pre-test. So there's the training of that probabilistic element without a reversal. Notably, those individuals who failed the pretest at one session were able to successfully complete it at a separate session. And similarly, individuals who displayed behavior that prevented them to complete the task at one session were able to subsequently complete the task at a later session. And interestingly, these individuals who are having difficulty with behavior in one session were also not able to complete other tasks, self-report measures, etc. So it really didn't seem to be specific to this probabilistic reversal learning task. It was a rough day for them. And we were able to test the test-retest reliability for this because we had a 5-week period between their screen visit and their baseline visit. And so we're showing fairly high test-retest reliability. And so it's nice to see we have some reproducibility of these across our different videos. Demographics, I'm just quickly showing, and this is for individuals who completed all the tasks at every time point. And so we're showing some nice sensitivity to detect change in the total trials to criterion. This is again most prominent compared to both T1, so that screen time, as well as baseline versus T5. Then it's nice that at T10, which is the treatment end, that we're also seeing those changes maintained over time, and we're seeing them at T20, which is 10-week follow-up visit. And so we're seeing this in the overall sample in green, and especially in those child sample as well, 8 to 12 range. And a little bit also that maintenance period for adolescents. Number of regressive errors also showed sensitivity to detect change. Again, this is in the overall sample, and we're seeing it both at treatment end and during period. So the takeaways is that the reversal learning task is highly feasible with over 95% success rate. It's reproducible with good retest reliability. It's sensitive to detect change in performance, and it may even demonstrate some specificity. I wasn't able to show the perseverative errors, but we did not see any changes in that, and only in the regressive errors. So again, maybe even showing that it can show specific types of change in cognitive flexibility. And again, I think this nicely highlights the intrinsic link between cognitive control and emotion regulation, and how as we're kind of maybe improving emotion regulation, we're in turn improving cognitive control. And quick acknowledgements. Thank you so much for the research funding and everyone who supported this task. Thank you very much.
Hello, everyone. My name is Rebecca Shaffer, and I'm an associate professor of pediatrics at Cincinnati Children's Hospital, and I'm going to be doing the Discussant section for today. It's an honor to join this great group of researchers earlier in their career who are thinking about ways to really measure emotion dysregulation and ways to include those measurements within research development for the future. So we had a great group of research that was really looking at multiple constructs within emotion dysregulation. I just want to spend a little bit of time reviewing those. So in Dr. Reisinger's presentation, we really looked at that physiological, biological underlying construct. And she was able to show us that non-ASD children show a strong relationship between physiological arousal and symptomatology. So we know when there's higher arousal, there tends to be more aggression within the typical population, which is a great reason to start exploring this more within the ASD population. And we know that kids with ASD have difficulty regulating their arousal. And it's been suggested that that then leads to maladaptive behavior because demands exceed coping ability. So within the study that Dr. Reisinger shared, she showed that collecting HRV is feasible, it's related to clinical measures within ASD, and it's sensitive to treatment change. So it really points to this as an excellent measure to be included within emotion dysregulation research in ASD. Does it have predictive value for who responds to treatment? Is it a possible physiological mechanism that's underlying some of this dysregulation? We can start to understand this more by including more heart rate variability analysis within treatment development studies, as well as studies that are looking at that underlying mechanism of emotion dysregulation within autism spectrum disorder. We also had an excellent presentation from Dr. Coffman about some of these underlying brain constructs. And she demonstrated that hyperconnectivity within and between the salience and default mode networks provides information about emotion dysregulation, but it's not yet a clear picture. There's more that we need to know about this. So the typically developing individuals had hyperconnectivity that then was related to difficulty in identifying emotions. The social anxiety participants had a different picture. So hyperconnectivity had better emotion regulation clarity and awareness. And then we saw with those autism spectrum disorder teens that connectivity had no association with ER on the clinical measure. So this needs to be explored further, right? We need to better understand how this relates to emotion dysregulation. And we know also that brains of individuals with autism spectrum disorder look different than other individuals their age. So do we need to explore different areas of the brain that might be related to emotion dysregulation specifically for autism spectrum disorder? And then how do we understand these differences between social anxiety individuals and typically developing individuals? And the answer is that we need more research. This is an area that needs to be expanded and continued in the future in order for us to really understand how brain mechanisms are related to emotion dysregulation. And then Dr. Schmitt helped us to think about the relationship of emotion dysregulation and autism to other constructs, so cognitive inflexibility in particular. And we are left with this question of what comes first and how are they related? So are children dysregulated because they're rigid? Are they rigid because they're dysregulated? We need more research in order to understand this connection better. But we're lucky because reversal learning shows promise to do this research. So it's highly feasible, it's reproducible, and it's sensitive to change in this population. So including measures like reversal learning in future intervention trials is needed to help us continue to understand these underlying mechanisms and related constructs within emotion dysregulation and autism spectrum disorder. So then we had a great presentation from Dr. Swain, who helped us to think about the transdiagnostic concept of emotion dysregulation. So she showed that children who were in the non-spectrum group and the ASD group had very similar rates of emotion dysregulation. She also helped us to see that there's some clear predictors across both of those groups of emotion dysregulation. So maternal education and spontaneous language were clear predictors, and then nonverbal IQ to a lesser degree was also a predictor of these difficulties. So this really helps us to think about, again, determining underlying mechanisms and how imperative that is. It has broader implications than just for ASD. It has implications for these children who also have internalizing, externalizing, and communication difficulties. And it really helps us to think about what are active components of treatment, because this then allows the expansion of emotion regulation intervention, not just within ASD, but also across other diagnoses. So the final thing I want to spend some time talking about is developing and tailoring future treatment for emotion dysregulation and autism spectrum disorder. So as we gather a better understanding of underlying mechanisms, that can guide treatment development and adaptations of available treatments. In addition, as we think about this transdiagnostic construct, It can help us to use the research that has been done in other diagnoses as a guide as we develop interventions. And I want to touch on the need for stronger measures. So we have some really great caregiver and self-report measures out there of emotion dysregulation. But if you noticed, each of these studies was using a different measure to collect that information. And it's important that we start to use some consistent measures across the field. So as we're doing research within emotion dysregulation and autism, we should be using several of these measures so that we can compare them across studies and really be able to rely on each other's research to help guide future research. But in addition to caregiver and self-report measures, we need these objective measures. So heart rate variability shows a great potential measure to include in studies because it's feasible, it's reproducible, and it's sensitive to change. Same thing with reversal learning and other computer-based performance testing. It's important to include these types of measures so that we have some objective data. And then finally, Dr. Coffman's use of resting state MRI is a great option as we start to understand the underlying mechanisms better. And then we're left with these two questions at the end. Can we identify what will work for who? And it's an important question because treatments work, but we need to know who they work for and how they work. And then finally, can we prevent emotion dysregulation from starting? So Dr. Swain's presentation showed us some great predictors, and there's the potential that heart rate variability is a predictor as well. So can we use these predictors to preventatively treat and help these children to develop skills so they never get to the dysregulated state? These are great questions, and this is great research. It's exciting to be a part of it and to start to think about the future of emotion dysregulation research within autism. Thank you so much for attending our symposium.
You do have a few questions in your Q&A session.
So I can go ahead and answer the first one. So there was a question about, is the Regulating Together curriculum available for purchase? It's not quite yet. It's going to be published soon, hopefully. We do offer trainings for it from Cincinnati Children. So if you were interested, you're welcome to reach out to me about that option.
And then I think, Lauren, you had a question about the reversal learning task. So what would be the difference between the reversal learning task and others such as card sorting and the Wisconsin card sorting?
That's a great question, and I apologize, I'm not sure why my video is not working. So the reversal learning task, we like to think of as a little bit more specific to reversal learning, and it doesn't involve as much other executive functions. So the Wisconsin card sorting or dimension card sorting tasks typically involve a lot of working memory, a lot more processing speed. It's extra dimensional, so you're not only just matching based on space, you're looking at shape, you're looking at color. And so reversal learning is just a spatial reversal learning task, and so it's really solidifying and like specifying that aspect of cognitive flexibility.
Awesome. Well, thank you all for your wonderful talks today. If anybody else has any other questions or anybody wants to pop in and ask questions via video. Oh, it looks like we have one. Lisa, can I let them in? Am I able to? Okay, all right, I'm gonna let them in. I have so much
Sorry, I just figured it's easier. I have a lot of kind of thoughts. I thought I'd just pop in on video. Thank you so much for putting this all together. One of the things I just kept thinking as I was taking notes and working through and also kind of thinking of things I'm going to add to my affective neuroscience class because they're obsessed with emotion dysregulation, is just thinking about how we really need to potentially as a field move more towards kind of creating a sort of repository. And I really appreciated kind of that conversation, particularly at the end of thinking through like, how are we going to synergize across all these different measurements? So I'm just curious if you have any suggestions for either people who are seeing these emotion dysregulation features in their populations, or kind of an idea of like, how could we as a field get to a point where we're sharing more of this data and really talking about these features? And thinking about like subgroups and kind of transdiagnostic pieces, like Marika and everyone kind of started to touch upon. So just ideas or thoughts.
Well, I want to say Marika and Deanna, you guys kind of touched a lot about like some of the subgroups, and so if you guys want to chime in and start off with an answer, or.
Yeah, Caitlin, thank you so much for your question. And I think like Rebecca, Dr. Shaffer mentioned this in that summary slide too, about how important it is, like you said, to cut across different studies and make sure that we're collaborating and building upon each other's work. And then when I think about subgroups, I think it's important to, like, one of the approaches I like to take is that machine learning approach, where it's really coming from like a data-driven approach, and then looking at what are the clinical phenotypes that emerge from that. Are there different behavioral characteristics or different underlying features that we might observe? And then, as you could see in my presentation, that doesn't always pan out in the way that you expect it to. Like those diagnoses might not line up, or the behaviors that you're noticing might not line up. And I think a piece of that is it might be the measurement that I was using. So maybe the DERS is not the best clinical measure, but maybe something like the EDI or a different tool that is maybe more widely used or validated in the samples that we're using might be more of an effective approach. So that combination of like being really intentional and thoughtful about those clinical tools that we're using, but then also the statistical approaches and how we use that.
To kind of echo on what Dr. Coffman and Dr. Shaffer mentioned earlier, you know, it's really important to kind of start thinking about comprehensive categorization of different populations too. So it's not just our ASD sample, we're also kind of getting to know those underlying co-occurring psychopathology that might present as well. And then, you know, when we think about measures to use and compare, it's kind of this double-edged sword, right? There are some measures that are available and widely used across disorders, across psychopathology, and they might not hold up as well in certain populations, which leads to the creation of more tailored questionnaires, which then gets back to your point of now we are looking at different questionnaires across different populations. So I think, you know, sometimes it's helpful to include both, and that can be tough as well. We don't want to overburden our families, but like you said, we really want to start understanding, you know, how this construct looks across individuals.
Mm-hmm. I think I can add, you know, sort of this other piece kind of in the context of the Regulating Together study and the reversal learning is that we saw that the individuals who came in with the highest amount of irritability, but lowest amount of dysphoria, so more a lot of that like kind of depressive anhedonia feel, were the ones that saw the greatest reductions in error rate on reversal learning. So it could be that, you know, that it didn't look like at baseline those subset of individuals were necessarily higher than the others, but they did show the greatest reductions. So there could be, you know, that a subset of these individuals are responding, at least in the context of cognitive flexibility, to that intervention most.
Yeah, and I would add that like with the heart rate variability, I think sometimes it's important we work forward, but then when we get forward, we also have to work backward. So in the study with the heart rate variability, you know, we found 11 participants were able to show change across the specific task over time. So it's really important to then, okay, we need to go back and look at those 11 participants and what kind of common features are we seeing within those participants to maybe see like, okay, are these the participants that are a good fit for this treatment and that we're going to see those long-term changes over time. So I think sometimes we get caught in the process of constantly moving forward and we forget to kind of take a look back to kind of look at those subgroups and who's really responding.
Do you just want to put a plug in for a measure really fast that is free and available? The inventory, the EDI by Carla Mazeski, has really, really great psychometrics, and it also has data within the general population. She did a US sample matched control group that compared the measure across the two. So that is one good measure that's out there. It's freely available and it has good data on multiple populations right now.
We've used the EDI and it has that contextualization in the schools because there's a teacher report as well as a parent report, which I think is really fabulous. So thank you all so much. I feel like there's a pre-conference here to grow.
Yes, future symposium or SIG.
All All right, any other questions? People can feel free to plug them into the chat box or jump on and ask questions. I know it's the end of the day for a lot of people, so a long day of talks. Well, I do want to thank everyone for coming together. We've come across several institutions to pull this work together. And so thank you all for contributing. Thank you, Dr. Shaffer, for putting together a wonderful synopsis of all of our work and really digesting it and comprehending it and spitting it back out in a very nice format. So I really appreciate that. And I appreciate all the work you ladies are doing to understanding this topic and moving it forward.
Thanks for being our leader on this.
You're so welcome.
Thanks, everyone.
Thank you. And thank you, everybody who attended.
Thank you guys for doing your presentations. We really appreciate it.
Thank you.
Thanks, Lisa.